Okay, so first of all, I would like to thank you very much for the opportunity to get meeting with you and to share our experience and knowledge of the exciting world of that very people that our failure is on the rise, and we get a lot of meetings to whom we dedicate our time on the new methods in clinical meditation. It's important for us to understand that more and more new method interventional ones as drugs are being, and we are practically very excited that because we recently had a chance to switch from one of the glucose-lowering drug to the treatment of diabetes. Now we explain to me how I show you my slides, and we can start. So should I press share or what?
I think you can start with your presentation.
Okay. So share, and then one moment. Right here. You see my slides now?
Yes, very clear. And
Okay, excellent, excellent. So what is important for us to know what we are dealing with? Although diabetes is the most important disease, and it has the same incidence and prevalence as, for instance, acute coronary syndrome, and it has much higher mortality than most of the cancers, heart failure does not get the attention it really deserves. And therefore, it is important for us to increase the awareness of heart failure. And showing again in this slide, which is one of my favorite, we understand that we are dealing with not only a very difficult condition, but also the condition which is progressive. And we need, if we do not preclude this line of development to the death. However, it is important to understand that this condition is one of the most pronounced spenders in the health system, and we get the way how to do it. In addition to that, we know that heart failure can be nicely prevented, and we designed some are a lot of ex-analytical factors which are influencing the selection of therapy, and they are very important because sometimes they are one who are deciding about treatment options in a particular country. Don't underestimate the importance of social, economic, and country-specific factors because they are one who are practically the most important in final also current people now. So, you know that Cardiocon Association is almost 7,000 members. We get all how we are going to place every method we are going to present now. And therefore, we decided at the beginning of 2019 to do so-called clinical practice update, giving everything, giving the role, everything which is new after the 2016 guidelines. Therefore, we sit and together all the knowledge which are all presented during the ESC meeting, and I'm going to underline the most important aspect. So we are all very much excited about the new way of giving patients with cancer. And scientific consultants is obviously one of the first ways not to mention scientific consultant was shown to decrease cardiovascular and all of organization. What is extremely important, and we are looking forward to that fact, is that scientific consultant is particularly increasing cardiovascular organization, all benefits the first candidate cardiovascular organization, which are the having all the treatment of the and the major reason for diagnosis. However, we learned some new things, and they came from the recently introduced pioneering study. Pioneering study actually gave us the idea that scientific consultant can be used very early after the acute decompensation of heart failure, and when we compare this study in a lab, in the setting of acute heart failure, we were able to show that the fact that arterial decompensation, elderly population, and transplant are happening in much lower number if the median consultant was used. So the normal need to be excellent and hazard ratio is also a greater. However, life is not easy. We know that surprises can be pleasant, but we are in much case unpleasant. I would like just to remind you that heart failure with preserved ejection fraction remains a challenge because Paragon trial with also sacubitril valsartan showed that the only fact and the only parameter which was affected is heart failure hospitalization. However, all in total, Paragon trial was disappointment because HFpEF stays as a diagnostic challenge for all of us. Sacubitril valsartan, however, improved the functional capacity of this patient as well as the quality of life. It was very good and very positive in the preservation of renal function in 3,000 patients in Paragon trial as well. What needs to be said, the females in Paragon trial had a better reaction, had a better effect of sacubitril valsartan, and also Paragon gave us an excellent understanding that although HFpEF was not treated properly, it was not reacted properly on sacubitril valsartan, the ejection fraction and heart failure with ejection fraction less than 57 improved, and it was also one of the proofs that left ventricular ejection fraction at the lower side will react very nicely on the effect of sacubitril valsartan. To make the long story short, it is important to understand that probably now sacubitril valsartan is one of the very important drugs for treatment of HFrEF. However, we are far from solving the problem of HFpEF. As I said, we need to learn more about sacubitril valsartan because in the 2017 study, it was clearly shown that sacubitril valsartan is decreasing HbA1c in the patient with heart failure and diabetes from visit 1 to visit 4, as well as it is decreasing the number of the new insulin users, which may signify its anti-glycemic effect to some extent and in the patient with heart failure and diabetes. Therefore, we were looking at one side, we are looking in one door. However, the surprise came from another door, and these are SGLT2 inhibitors. Let me remind you that these drugs are extremely important in treatment of patients with heart failure and diabetes, and starting from the strongest study, EMPA-REG outcome, the hospitalization for heart failure in this group of the patient was decreased. CANVAS program with canagliflozin also showed the reduction of cardiovascular death and hospitalization with heart failure, as well as declared TIMI 52. The characteristics of the patient involved in TIMI 52 declared study were a little bit different, gave us some information about possible prevention capabilities. However, what was clearly shown is that rehospitalization for heart failure are here to stay and are very pronounced under the effect of these drugs. As you can see from this collaborate work on EMPA-REG, CANVAS, and declared TIMI 58, it was clearly shown that heart failure hospitalization was reduced. However, after most of our knowledge in that field, we also learned in the ESC Congress that TAPA-HF was having an excellent effect of reducing cardiovascular death, heart failure hospitalization, and urgent heart failure visit, not only in patients with diabetes, but also in those with heart failure. I may say that that was a breakthrough statement in whom we practically learn that DAPA may be our future collaborator in fighting against heart failure, and you can clearly see that all patients with or without diabetes are practically very nicely treated and have a positive long-term outcome as far as heart failure, cardiovascular death, and all mortality is concerned. The new thing and the new player in the field are potassium binders. You know that potassium is the negative effect when we treat our patients with heart failure, because they may also have the renal impairment, but they will also on the drugs which are by its pathophysiology increasing the effect of potassium. The idea is to use this drug to achieve the optimal dosage of ACE and other renin-angiotensin supplementary drugs. And you can see in PEARL-HF, the hyperkalemia was nicely prevented without any side effects, but also with the possibility to optimize the use of renin-angiotensin aldosterone antagonists. There are two drugs of a kind. One is patiomer, and another one is ZS9. We will believe that in close future we will have some more studies which will inform us about the real clinical value of potassium binders. Going ahead, I would like to let you know that amyloidosis, cardiac transthyretin amyloidosis is now in very much focused, because what we know is that some of the patients with the hypertrophic forms and some patients with clinical phenotype of restrictive cardiomyopathy are practically having the amyloidosis, as it clearly can be seen from this slide. TTR stabilization with selective tafamidis is something which can prolong the life of this patient by stopping the further accumulation of the amyloid within the heart. This paper and this communication was very exciting, because it gives us the possibility to proceed with something which we were not able to treat before, but we were also the blind witnesses how the disease is developed. So tafamidis is here to stay. It is very expensive, but when we find the right indication for these drugs, we think that it will be of the excellent clinical value. Dear friends, dear colleagues, ladies and gentlemen, it is very important for us to understand that treatment of heart failure should come from both ethical and economical argument. What the situation is right now, we believe that we first need to use the drugs, and if the progression of the disease is not halted, and if we need to use the devices, we should proceed with the more complex and more expensive therapies like devices. Therefore, we can offer to our patients now interventional heart failure, which is obviously comprehensive and multidisciplinary treatment, which includes a lot of different methods. Some of them were developed during the past 10 years, but some of them are quite new, and it seems that the clinical studies are practically very good in underlining the clinical application of this method. ICD is very important for us, because we know that 1/3 of the patients with heart failure are dying for a sudden cardiac death. The use in secondary prevention is 1A, plus of evidence 1, level of evidence A. However, when it comes to the primary prevention, we are more and more convinced that depending if the disease is of ischemic and non-ischemic origin, we can use this method to the different extent. You may know that understanding of our CRTD or CRTP application were improved very much, but the Danish trial, in whom the hypothesis that prophylactic ICD in patients with non-ischemic cardiomyopathy is not useful, not clinically beneficial. However, when we did the sub-analysis of the Danish trial, we find out that among the younger patients, ICD implantation was associated with the benefit, and therefore it should be the clinical effect to use ICD in this group of the patient. What we should have also paying attention on is that if a patient had more advanced symptoms or life-shortening comorbidity, we should be very much looking for the proper indication to put one ICD. CRT, and I was happy to be in one of the very interesting Heart Failure Association workshops 2 days ago, how to improve and advance the cardiac resynchronization in heart failure. You can clearly see that in group of the patients with QRS duration of more than 150 seconds, left bundle branch block, and ejection fraction less than 35, despite optimal medical therapy, the ICD may be the treatment of choice. However, we defined very nicely several clinical factors which are influencing our response to CRT, and we find that wider QRS, left bundle branch block, female sex, and non-ischemic cardiomyopathy is something which is here as the major identification of the responders. Atrial fibrillation, very common comorbidity with heart failure association, and you know all Kestelayev, in whom the primary endpoint of death or hospitalization for worsening of heart failure was shown to be significantly affected by application of the ablation. A little bit later, Cabana trial, in whom no significant changes gave us to thinking that we need to learn more about that. But when you come to the mortality and cardiovascular hospitalization, we know that 17% reduction in mortality or cardiovascular hospitalization in the indicated patient was achieved. Therefore, let me conclude my presentation with two very exciting areas. One is the treatment of functional mitral regurgitation. And this comprehensive slide gives you the idea that mitral valve dysfunction leading to left atrial dilatation is associated with the higher mortality and several comorbidities in whom the patient with functional mitral valve presented in almost 70% of our heart failure patients is occurring. Therefore, two big studies, MITRA FR, in whom patients with heart failure and severe mitral regurgitation were compared with optimal medical therapy alone. It was a 300 patients trial in whom no significant difference between the implantation of the mitral clip device and optimal medical therapy was revealed. However, if we look at a recent publication from Obadia, who was the main author in this paper, they will also found that there were no significant difference in 2-year follow-up. However, the good thing with cardiology is that it is never stops. The people are thinking, the people are curious, and Greg Stone was one who put together COAPT trial in whom the 600 patients were analyzed, and the final result of all hospitalization within 24 months showed the clear-cut evidence between the control group and device group in terms that the device group has lower mortality and lower all other follow-up complications. We obviously can find some explanation about this difference as far as the mitral regurgitation grade, which was much less in MITRA FR, but also about the size of left ventricle and the higher left ventricular end diastolic volume in MITRA FR in comparison with COAPT. That underlines once again the clear-cut identification of the subgroup of the patient we can use some of this method. Needless to say, the last part of my talk will be directed to the advanced heart failure, and you are looking at one of our position papers in whom we underlined that third generation left ventricular assist devices are very important in treatment of heart failure. Obviously, Momentum 3 trial done by Mandip Mehra from Harvard exclusively showed that HeartMate 3 is much better than HeartMate 2, but at the same time showed that the centrifugal flow left ventricular assist devices may be advantageous comparing to axial flow left ventricular assist devices, and that they are an excellent way to treat end-stage heart failure. Also, it is very important that one of the major controversy in this field is the treatment of left ventricular assist devices in the patient which are the destination therapy, which means that those patients will have the implantation of left ventricular assist device as a final treatment because all of us are very much aware of the shortage of hearts for the heart transplant procedure, as well as the high cost of this procedure. Ladies and gentlemen, let me conclude that saying that not only Heart Failure Association, but also all others are working hard on all aspects of everything I try to underline you in this short 27 minutes talk. It is important for us to understand that this battle is ongoing. We need to learn more about our new drugs, our new methods, and we need to keep up with the several of most important and most promising directions we use to improve our armamentarium against the fight of heart failure. I would like to thank you very much for your attention.
Thank you. Thank you very much, Professor Peter, for an excellent presentation covering the drugs and the devices in the management of heart failure. Can we have a couple of questions with you?
With pleasure, please, with pleasure. We had an excellent discussion time last time I was with you, and I enjoyed very much. Please.
Any questions from the audience and the panelists?
Dr. Peter, is that what is their experience of using combination in heart failure regarding pharmacotherapy like ARNI plus EMPA or DAPA combination both in diabetics and non-diabetics?
Peter, did you get the question?
This is a very common question, and let me underline that the art of medicine is practiced on the first place by having common sense what the patient has. I was very much involved in both Paradigm and Paragon, and I understand that ARNI are a very important therapeutic principle. However, it seems when we started to apply sacubitril/valsartan in the real world, we were experiencing some of side effects which are not extremely dangerous, but they are unpleasant, like for instance hypotension. So we fought with that with decreasing the number of the drug. So if you apply the sacubitril/valsartan on top of beta blockers and probably MRIs with the proper dose, you will see that the patient's feeling and the improvement of the functional status is amazing. And now we have a new therapeutic principle, which is SGLT2. So I think that we need time, first of all, to confirm the place and the importance of the SGLT2 on the top of the other drugs we have in heart failure. And then we need to learn, and I was yesterday in one of the advisory boards in whom we discussed the mechanism of the effect of SGLT2 in heart failure, and we were not able to give the final answer. Therefore, it is very important for us to approach the application of these two drugs slowly, and also having the possibility to improve the long-term outcome of the patient does not mean that we should jump into anything which we not investigated carefully. Comparing sacubitril valsartan and SGLT2, you will obviously agree with me that SGLT2 are much easier to apply than sacubitril valsartan. Therefore, I could not answer your kind question, but what I told you is the approach we need to develop in the next years in order to see how this combination will work.
Yes, please. Another question, Peter.
A very nice presentation, Dr. Peter. Regarding the SGLT2 inhibitors, there is a bit of a concern regarding the UTIs or the fournier gangrene. What truly is it? Is it UTI more common, or like what should we be doing regarding the treatment?
UTI are, I mean, they are comply with the mechanism of activity of the drugs. I will not worry too much about that because the higher hygiene level and warning patient that any of these complication and infection can occur will solve the problem. However, what I think that DAPA-HF was one trial. You know that if we are really critical, we may see that all of these drugs are having the pronounced effect on the heart failure and diabetes. However, the first one, EMPA, had the strongest effect and has the overall effect on all-cause mortality, cardiovascular mortality, and heart failure hospitalization. Therefore, I would like to warn you that we probably need to wait until 2020 when Emperor reduced and Emperor preserved will be presented, and then we may know a little bit more how we are going to approach to the use of these drugs. You know, if Emperor, for instance, Emperor reduce is positive, that means that this drug, which came from the field of diabetes, will have one A recommendation, and that, and I think you would agree with me again, will come as a big surprise to all of us.
Thank you very much, Peter. It has been an excellent communication with you, and your present has been excellent. And I think the question answers, we were able to cover nearly most of the subjects that we wanted to. Now, can I request you to be in Pakistan next year if we...
Absolutely, absolutely. I just would like to say, if I was useful, it is, I'm really happy, but I mean, it is always the pleasure to exchange the opinions for you, and you know that both Heart Failure Association and ESC is absolutely ready to help and to involve you in any of activities we have, and you've seen from my last slide that we are doing a lot, and we are really happy to cooperate with your society. Thank you once again very much.
Thank you very much, Peter. Have a great weekend.
Okay, bye-bye. Bye.